Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. I'm looking forward to our episode today. We have a great topic picked out and always fun to banter.
Yeah, absolutely. Well, that's what people love about us, apparently. We're looking at some reviews, and I think people enjoy the conversation that we have, and they like hearing you squirm when we talk about nerve, and hearing me get uncomfortable when we talk about arthroscopy. So yeah, I think it's a fun time.
Yeah, I can share a quick anecdote, but I would love it if maybe you have a review or two to share.
Yeah, I have a review to share, but also, isn't it amazing that we are over 220 episodes in?
It's
It's
crazy.
insane, right? So we've been doing this for a long time, 5 years, over 5 years, which thank you to everybody for keeping us around. So I'm surprised that we haven't been voted off the island yet.
It's yeah, over 500,000 downloads, and that's excluding video, which seems to be exploding. People seem to like to look at our faces, which is shocking to me. But we're not doing anything else than sitting here
I
talking.
I think it's that it's easier for people to turn us on while they're doing other things and are probably not looking at our faces, but just have the audio on in the background. I'll tell you that.
I disagree. I think they like looking at our faces.
No, no, definitely not. That's why whenever I go and speak somewhere, they're like, "This is weird. Like we're seeing your face, but we're used to hearing your voice." So,
Yeah.
anyway, we wanted to thank Dave James for this great 5-star review that he left for us a couple of months ago. He says, "Loved this," when I think we were talking about a carpal tunnel episode, and learned so much in medical school for all things CTS, wrist, hand, and elbow. Dr. Chuck is inspiring me to go back for an MBA. Dr. Chris's sharing on his athletic endeavors are fun too. Athletic endeavors. Keep up the great work and thanks for lending a hand. Dave
Nice.
James. See what you did there at the end, Dave. Thank you
Uh,
for doing that.
Thank
Thanks
you,
for
Dave.
shouting us out. Thanks for the 5-star review. We do like to hear from folks, as everybody who personally knows me knows my love language is words of affirmation. So please continue to shower us in affirmations.
I don't know my love language, but I do have two things to share.
Of course you do.
Number one, at the recent iFesh meeting, there was an outpouring of people who wanted to talk about the pod, which, as you know, I'm grateful for. Um, Several of them commented that they want more congenital. The people are
It's
speaking.
because the people that find you like congenital. Like there's definite bias in how
No
this
bias.
works.
There's no bias. And the other thing, and I wouldn't say his name even if I knew it, but I was walking and someone said, "Hey, Dr. Goldfarb, how are you?" And I'm like, "Oh, hey, good to see you." And he kind of paused. This is classic Chuck, screw up. And I said, "Great to see you. It's been too long," or something like that, just trying to wing it. He's like, "I don't know if we've ever met, but I do love the podcast." And I'm like, foot in mouth. What a dumbass I am.
I've become better at just being like, I can't remember how we know each other, or do we know each other? Just like remind me.
Yeah, it's funny.
But I will say I'm not great at like because for some reason, when I changed phones, it didn't update all of my contacts. And this was a couple of years ago. So there are still people who will text me and I'm trying to figure out like, do I just tell them like I don't know who this is? Or do I like try to like ask other people who this might be or like look it up in my old phone or something?
Or wing it and hope it becomes clear.
Exactly. So I've had to do that recently. So I'm trying to just be like, hey, I'm sorry, who is this?
Yeah, it always takes me back when people ask that. And then, once you explain, it's fine. But here's my second thing is that in business school, we did an entrepreneurship section, which I loved. It was awesome. And, I guess part of the reason I was interested in business school is the fact that my wife did run a business for a long time, started and ran a business. So I love this section. And it is absolutely applicable to all of what we do, just thinking with that mindset. And certainly in medicine, we talk about as a department what can we do differently and where are our opportunities? That's all the same mindset. But we did have a competition, and I'm going to probably potentially give someone a multi-million dollar idea right here.
Don't do it.
I,
Don't do
I'm
it,
okay.
man.
I'm okay. So here's my idea, and I'll have you know that this idea won the
You
competition.
won.
I won.
Nice.
And the
Congrats.
and so it started with we have groups. There's about seven groups, ranging from 4 to 6 people in a group, and we have a great group. And everyone presented their ideas, and my group selected my project. And my project was a podcast network based on what we've done here and the concept of edutainment in medical podcasting because that is what we do. I think we
I
do
like how you
provide
think you're
education.
an entertainer now, you know?
I'm an edutainer. I provide the seriousness, you provide the entertainment. But and then we presented in front of the judges in the class, and it was chosen as the most promising idea. It will be very challenging if we ever decide to proceed with that, but it was fun.
Yeah, it's just so hard to find that many Chucks out there, you know? It's people that are so engaging and charismatic that people will want to listen to them to talk about musings on, I don't know, wrist, knee arthroplasty or something, you know? So, well, congratulations on the win. That's huge. I remember when I first heard the term sports entertainment to describe professional wrestling. Now we're in educational entertainment or edutainment. That's great.
It's edutainment that builds community. And I think we have, if we had only recorded ourselves back 5+ years ago when we thought when we launched the podcast, number one, we were like, who's going to listen to us? Do you think Talia, will our wives even listen? The answer is definitely no on the
Yeah, definitely
wives.
not. Definitely not.
And how long will this last? Will it last a month? Are we self-indulgent for doing this? Anyways, the whole thing's fascinating.
I guess they answer the question. We don't know how long it's going to last. And yes, we are self-indulgent as our partners who begrudgingly know about our podcast and hear about it during the interview process will tell us.
That is very true. So one thing we haven't done in a while, actually, before we jump there, let's thank our sponsors.
Yeah, the upper hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource. Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
Oh, you did the whole thing. You just
I didn't
cutting me
realize. I
out.
just, yeah, my daughter was walking by, so I just in the zone. So just went ahead for all of it.
You did it really well. So I think what we thought would be fun is sharing our favorite and least favorite procedures today. And these things evolve. As I get older, the longer the surgery is, the least likely I am to be interested in doing it. But I think it's a fun topic.
I do, and I think I'm gonna throw you a bit of a curveball with my pick on my current favorite surgery.
Oh.
But it's good to talk, and I think that it is interesting. I'm sure the longtime listeners may notice how feelings have evolved over time.
Now, we should define what we mean by favorite or least favorite surgery. When I think about those terms, for favorite, I think about number one, enjoyable to do, and number two, predictable, strong outcomes. Anything you would add, or would you say it differently?
No, but as you've now laid out this criteria, I'm wondering whether my pick is appropriate. So, to be fair to those that are listening, I did not know these criteria when I selected my favorite surgery to discuss right now.
Well, you can define your own criteria. It'll all be fun to discuss. Do you want to go first?
Sure, I'm happy to. My current favorite surgery is actually, drum roll,
Drum roll. I could put a drum
LR,
roll in.
exactly, LRTI.
Wow, I am stunned. Explain why that is.
It kind of feels nostalgic, to be honest with you. I've done a few recently. Some are because for revisions, some are for the context of patients already having that done on the other side and wanting it done. But it feels right to go back to doing something that I learned in training, and like you said, has predictable outcomes. Not that the other way that we've been doing it recently is that suture tape suspension. Not that that doesn't have predictable outcomes. I've liked that, but I think that I've opened up more. I'm more willing to do an LRTI now. Yeah, and some of it is, I think, honestly, it is trainee driven because I do think that our trainees need to see it and do it, and I want to make sure I keep my skills up on it because if you I actually hadn't didn't do an LRTI for at least 3 or 4 years at one point, so it was good to get back on the horse.
Yeah, I think that's I love that. I love that. And let's just state that these are not any order. It's not one through whatever, 1 through 10. It's just what we're thinking of. I'm going to surprise, if you're going to surprise me, I'm going to surprise you.
All right, here we
Um,
go.
and when I think about my current practice, which is increasingly larger surgeries, like in the last few weeks, all my surgeries have been an hour and a half to 2 hours with
That's
no,
uncommon for you.
it's absolutely evolved in that way over the last couple of years, but I still have typically had a balance of some local onlys or whatever. Last few weeks, none of the small stuff. Um, and I like doing those medium-sized cases, but I miss doing, drum roll please, carpal tunnel.
Carpal tunnel?
There's just something so nice. It's simple, it's predictable, and in the right patient, outcomes are excellent. You have to see the patient only once post-operatively. I like it. It's just a good surgery.
Yeah, no, I think it's reliable, which is what we're looking for. And as we talked about in a few episodes back, when you find the sweet spot in terms of when to operate on the patient and they come to you at the right time, people are really, really happy. They love being able to sleep through the night, not getting bothered during the day. I mean, um, it's a nice thing because again, you tend to only see them very limited after surgery. And sometimes if you use dissolvable sutures and everything now, you could just see them on Zoom once or have them give you a phone call. I've started to give people that option. And honestly, changing to a dissolvable suture has helped a lot in terms of decreasing or minimizing any, workflow stuff when they come back.
Oh, interesting. Do you have a, how do you, I don't love dissolvable, but teach me something. How do you do it?
Yeah, so I back in 2023 when I visited our friend Sam Mogdeteri in DC, he was doing dissolvable sutures. I think he was using Sam. I'm sorry if I get this wrong. I think it was a fluoromonocryl as a deep dermal and using Dermabond on top of that, so a skin adhesive on top. Um, and I came back and shifted and started doing that. I have now evolved thanks to one of our fellows, Nick Collada. He provided some input on different suture and needle choices, as the plastic surgeon tends to do. And we switched over to a 4.0 PDS just because the needle, the P3 needle, was available. And I think maybe a 4.0 monochrome might be in the future, just in terms of a couple of reactions. But doing that as a deep dermal buried suture, and then putting Dermabond on top, has helped because now we don't have to take out sutures in the office. I was using 4.0 nylons. And I'm sure people, please like let us know your preferred closures and whatnot.
Yeah.
Um, but it's made everybody a lot happier. I do that for carpals and triggers, which before I guess I was always taught like on the Glaber's portion never to do a dissolvable stitch and a skin adhesive. But it saves so much time.
For sure. I've stuck to nylon. I've been happy with it. When I've tried to do dissolving, I haven't been as happy. So it's good to hear. I'll maybe here's Chuck's hot take. I would prefer carpal tunnel over trigger. I think carpal tunnel is more predictable for the patients I choose to operate on. And I have a small percentage of trigger patients that just make a lot of scar tissue and aren't happy. And it's not a big problem, but it's a problem that requires a conversation and repeated conversation. Is that your experience or is that just me?
Yeah, no, I have up until about 6 months ago, my conversation with patients about trigger finger release was that your scar might be painful, and you may have an issue with the scar and with scar tissue afterwards. It's uncommon. I had at that point one patient with a painful scar whose triggering went away, but was very unhappy with how painful his scar was. Flamed me in online reviews, etc. Uh, So now I tell him like, look, I have this one patient who had a painful scar. And now since then I've had one more patient with a painful scar. So now I have to change my conversation to saying that I've had a couple of patients that have had, no more triggering, but a painful scar.
Yeah, I mean, I send no one to therapy for carpal tunnel. Like, I can't remember the last patient I sent to therapy, and I don't think we should. Occasionally, more commonly, I would say once every few months, I'll send someone with a trigger release to therapy to help fight scar tissue. It's crazy.
Yeah. Yeah, no, I don't think that's come up for me as much, but I think the more vexing thing about trigger finger, I think at times is I've tried based on literature, I've tried to look more and note more of these PIP contractors, so the grade 4 kind of triggering with the contractor because more papers have shown that those patients don't do as well. Um, but then in pointing that out to people, they then fixate on it, which kind of stinks. So I tell them, look, your joint's stiff, which means that you're probably not, as likely to do as well as somebody who came in earlier, et cetera, who was treated earlier. And then they say at the end, they're like, well, this hasn't gotten any better. I'm like, well, damn it. It wasn't supposed to get better.
All right, let's do the snake technique. That means I get two before you can now get two.
Okay, got it. Got it.
Um, so I
Another
have
favorite?
Yeah, another favorite. I mean, I have
Cool.
to throw it in there, politicization. I mean, it's the reason I like a policy. There's a number of reasons why I like politizations. Number one, we do a high volume of them, probably 10 to 12 a year, which is a lot. And I say we, that's the other reason I like it. I do these with my partner, Lindley Wall. It's fun to operate with partners. And number three, it satisfies the orthopedic and plastic surgeon in me, I guess I would say, because it provides a functional and an aesthetic traumatic improvement when it goes well. And families are really happy. So I love that operation.
That's great. And
Top that.
that's such an amazing surgery, right? Like to think conceptually that you're making a thumb. Like that's just really cool. Like,
Cool.
so I can't top that. But one other of the current things that we're into, if you're going to go very niche, is
I went there. I
for
went
a
there.
panplexus patient,
Ooh,
a vascularized ulnar nerve flap.
oh, sweet.
So very, very so. And one of our friends, friends of the pod, and a personal friend, Johnny Liu, over in Chang'an and Taipei, in
I saw
Taiwan.
Johnny. I saw
Yeah,
Johnny at the meeting.
awesome. Yeah, he was a big presence at the iFesh meeting.
Yeah.
Social media superstar. And so he it was we started doing this Tricontinental Nerve Congress, a conference, even before Zoom. Like we would do it. What was the program that was around before Zoom? It still is. It's a WebEx.
WebEx.
We were
Nice.
doing WebEx because we found that 6 a.m. or 6:15 in St. Louis is 6:15 p.m. in Taiwan and lunchtime in London. So we set up a conference after I had come back from my visit to Chang'an, and I met Tom Quick, one of our other nerve friends in London. I met him on Twitter, and we ended up meeting up at a nerve one of the ASPN meetings, IRL. And so we set up this conference to talk about cases, and it's evolved over time. And Johnny has been very hot to trot on this vascularized ulnar nerve flap. And it's in the setting of a panplexus in which usually you have like a C8T1 avulsion in that context, and the ulnar nerve is not going to come back. Like it's not. So it's a very useful spare part. And the limits on using a standard kind of cabled sural autograft is that it's only going to make it so far. The cable graft is only going to work so far because of A, the limits of nerve regeneration, and B, the fact that you're putting in something that's not vascularized. So you're relying on the surrounding milieu of soft tissue to kind of grow in and vascularize the cable graft, which can only go for so long. So when we're putting these longer grafts in, which unfortunately you need to do sometimes for restoring shoulder or elbow, the vascularized ulnar nerve flap is a great tool, and it keeps our partner, David Bergen, happy because he gets to do another flap. He loves that. And it's honestly, it's way more fun to sew that in than sewing a cable graft up in the neck. So I've enjoyed doing that. I think that we're early in our experience. I don't know if we're going to be able to replicate what's been done in Taipei. But I think it'd be interesting to see if that shifts our outcomes.
That's amazing. It makes all the sense in the world. Plus, I think he used my love language there with milieu. When you say that word, it's just awesome.
There's so many things that I pronounce poorly, and I hope I did not botch that one.
You didn't. It just got me. All right, you get one
A funny,
one one.
there's a little funny anecdote. I was teaching our lovely chief resident, Caroline Granger, about um, ulnar nerve palsies and ulnar nerve injuries. And of course, I actually pulled out your classic article that you wrote with Dr. Stern from the Journal of the ASSH, which is actually no longer available to download. So I had to
No.
dig it out of my Dropbox and send it to Caroline. But we talked about, the different ways that you test, to look at your possibilities for different tendon transfers. And as everybody, listening probably knows, you flex down the MP joints and see if you can get active extension at the PIP and DIP joints in a maneuver called the Bouvier maneuver. Uh, I love this, and Caroline's wonderful, but she mispronounced that.
It's
And
just so mean.
maybe I'm mispronouncing it. Yes, let's be clear. I might be saying it wrong. And I won't say what how she said it, but it was a very funny moment in clinic.
For a Southerner, mispronouncing, French words especially is a commonality. And so I do think it's Bouvier, but and I'm sure everyone got a good laugh because we screw it up all the time.
Yeah, the Francophiles on the call are
All right,
going to be very disturbed.
you get one more.
One more favorite? Hmm. I'm ready to move on, actually.
Okay,
I'm ready to
wow.
move to least
Okay.
favorites. But if
All
you
right.
want to go on to another favorite, go ahead.
All right, let me tell you one more. I'm going to put a couple together. I really do think, as my wife would say, she's playing a lot of mahjong lately. If anyone has any mahjong comments,
Oh,
and
yeah,
so
my
she,
wife, Tiffany and Talia need to get together.
oh, I will tell
That
her.
was the Mahjong Club last night. with
Oh.
with one of our other friends. So we should get them together.
Oh my God, yeah, she's in her mahjong era, as in
Ah,
a
yes, the
Taylor
era.
Swift. Yeah,
Yes,
yeah.
yes, yes,
And so
yes.
I'm in my arthroscopy era, and so elbow arthroscopy, especially for adolescent pathology, is giving me joy, even though it doesn't necessarily satisfy the uh, always predictable outcomes, but I really enjoy it, and clearly wrist arthroscopy, especially for ulnar-sided pathology, I really, really, really like. Not so much for SL, but I think that's on me, not on what the options are. I need to get better. But arthroscopy is still a good one for me.
You've been in your arthroscopy era for a long time.
I think what's changed is the proportion of surgeries now. I think
Mm.
probably half of what I do on a busy Wednesday is arthroscopy at this juncture, which, there can be too much, and we've talked about that. Like
Hmm.
there's a sweet spot in cases, and you do too many, and it wears on me.
So speaking of current parlance, let's talk about our big nerve energy here. So the upper hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. As a hand surgeon, you know that nerves matter. It's why Checkpoint Surgical is singularly focused on elevating the clinical practice of peripheral nerve surgery with innovative technologies that help improve patient outcomes.
Checkpoint Surgical's portfolio includes a range of handheld intraoperative nerve stimulators, nerve cutting instruments, and biomaterials. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery. And I want to thank you for allowing me to participate in the sharing of this information uh, this time.
Not just reading the entire copy.
That's right.
So least favorite surgery. Like all of us, you're kind of scarred by recent experiences. Revision thumb CMC arthroplasty.
It's interesting. I wouldn't put it there. Tell me why.
It's just this particular one was a challenge because it was just converting we should talk about this at some point, but I think I can count on I think two digits the number of times that I've had to revise a suture tape suspension. And this was one. And it was just there was just so much difficulty confirming and finding my FCR, which I had found the first time around and protected. But it just led to a stress level of, finding the FCR and making sure it was okay, and then on the way down trying to find my dorsal branch of my radial artery, making sure that was okay. Just stuff that had been dissected out in the past and clearly identified as just stressful knowing that I'm relying so much on my FCR and not bagging my FCR as I go back in.
Whoa, that was super weird. We just had a delay. Are you there? Can
Yeah,
you?
I'm
Okay.
here. Do you need me to say anything again?
Um, yeah, unfortunately, probably the whole thing. So tell me why, why you feel that way about revision CMC arthroplasty.
I think that any revision surgery is challenging. It's just in general. I think the counseling is different. And then pre-op and trying to tell them what to expect, and that's based on both anecdotal experience and the literature. And then this time it was, I can count, on I think two digits now, the number of times I've had to revise a suture tape suspension. And this was, the most recent one. And, I had to make sure that I found my dorsal branch of my radial artery. And that can be stressful working through that scar tissue and getting that clearly out. And fortunately, we did. And then knowing that, in this particular case, I was relying on my FCR. Being intact. And, typically what I'll do when I remove the trapezium is that I'll say, hey, that's the FCR. Make sure you protect it because you never know when you're going to need it again. And it was stressful to find that FCR and get
For
down
sure.
there. And, and fortunately, everything went smoothly. But this was also in the context of needing to do a thumb MP arthrodesis at the same time because of the MP extension deformity. So there's just a lot of things that, like, I don't, um, that did not bring me joy until the end, and it was fine, and it
Yeah.
went very well, and I'm happy with it. But it's just, the stress level in that case is a little bit higher.
I think that's well said, and I've done different things in that setting, and we can make a whole episode about this. I've started to avoid the CMC space and just do, and I'm not aligned with this company, but I do a little mini tightrope where I'd simply go in, distract the thumb, and connect the first and second metacarpals, and I've been happy with that approach to avoid the challenge that you described.
Yeah. So, but I like I mentioned, one of my current favorite surgeries out is an LRTI. So it's always nostalgic to go back and get that FCR tendon and make your tunnels and everything, and just brings me back to the wonderful days of fellowship training.
Absolutely. And I'll share one of my least favorite surgeries that I do regularly is cubital tunnel treatment. And the surgery itself, if it's a larger patient, the fatty tissue is frustrating, but ultimately the actual doing of the surgery, I don't mind terribly, although, it can be frustrating and especially in those patients where you need more exposure to create a nice path for the nerve. Um, but what I don't love is that it's not always predictable the results. I don't think I can, I tell patients that 70 to 80% will be very happy with their outcome. And I don't get more specific than that for the other 20 to 30%. I generally think most of those patients will do better. And this is a huge topic, which we're not going to resolve here, but I just don't love that operation. I do it regularly, but don't love it.
Yeah, and I mean, you do it regularly, and I know that you do it well, in the words of LL Cool J. But it's frustrating when you think that technically from an indications perspective, you're doing what you feel is appropriate based on the literature. Technically, you do a surgery well, and then you can't deliver the high five outcome that everybody wants. I
Yeah.
totally get that. But it's a common surgery for us to do, and I don't think there's anything better that's going to replace it coming down the pike. So yeah, I feel you on that one.
No, it's exactly right. Do you have one more, either a thumbs up or a thumbs down you want to share?
I think that interestingly enough, like I saw a patient recently who had a de Quervain's release done somewhere else and just isn't happier. And I'm not sure, like, was it whoever did it first? Is it something different going on? Is it different, is there a diagnosis that was missed? But I saw a couple of patients with this recently. Until these last couple of patients, I always thought the Quervain's was a very reliable surgery. And it's making me question whether de Quervain's is a very reliable surgery.
Yeah. I don't do much of it. I hope no one does much of it, so to speak.
Right.
I think I've been generally pretty happy, but gosh, if I do 5 declarations a year, that I would say that's a lot. I do always offer splinting post-operatively,
Hmm.
just to. I've seen subluxating tendons after surgery, and don't want to ever see that in my patients. Maybe that forced immobilization helps with the predictability, but I guess I haven't had that experience, but I recognize it exists.
Yeah, no, I hadn't either until this. So it's interesting for me to, as as I get older, and kind of get more introspective on practice, you don't want to take for granted the things that work out well in your hands. But you also don't want to assume that everything is going to continue to work out. So I try to think about things that maybe we could be doing a bit better. But I've liked doing that surgery awake. I don't typically do a lot of immobilization. Currently, for things like that and for ganglions, I do a soft dressing afterwards, and I switched them over to a cock-up wrist brace 5 days after surgery, just to provide some reminder not to do stuff, but to allow them to have some more liberty with their limb. And we could talk about something, at some point, just little things that you do to try to help with, satisfaction.
Yeah.
And that's one of the things that I've changed because I used to just leave them in a big bulky dressing or a splint until 2 weeks post-op.
Yeah, interesting. That would be a good conversation. Little tips and tricks. We could probably bring Macy on to discuss because, as we've said many times, sometimes the therapist has a better sense of what patients really want than we do.
And what they want and what bugs them. I've changed some things in my peri-op protocols based on feedback from our therapy colleagues. It's very useful because they have the patients will share things with them pretty freely.
Yeah, that's exactly right. I maybe my last would be I enjoy bony work, whether that be scaphoids or distal radius, and they're not always completely predictable, especially scaphoids. But just the carpentry that sometimes is required, going back to our orthopedic surgeon roots, it does give me joy. Not exclusively by any stretch. I want to do other things, but I still like, a straightforward fracture is fun to treat.
Oh yeah, I mean a straightforward distal radius fracture is fantastic because it's a fun teaching opportunity. Comes together nicely. It's very clear that you've accomplished what you want to do, and it has a pretty predictable outcome for the most part.
Yeah.
Same thing, like one case that's like best, most favorite, and least favorite in the same one is like a proximal phalanx fracture that you're fixing. Like if that goes well, it's great. But definitely those can bring you to your knees, and those can be super challenging. So stressful, but then if it looks awesome at the end, you're like high fiving.
That's exactly right. That's exactly right. All right. This has been fun.
Absolutely. It's been fun. For those of you listening, send us a note at handpodcast@gmail.com if you have anything you want us to talk about. We do have a couple of things stored up in a mailbag from various folks, including topics like TOS, which will be super fun, as well as radiation treatment for de Quervains. So a couple, or not de Quervains, for Dupuytren's. So a couple of different topics we're going to save for a grab bag episode. So if you want to email us some additional topics, please do.
If you want to share your favorite or least favorite surgeries, we would love to hear them. We can share them online and debate whether you, the listener, are right or wrong.
Yeah, and your peri-op pearls to make life easier. That would
That's
be
right.
really great if anybody wants to submit those, because I would love to learn
I may,
personally. So
I may put that in the show notes. That is a good one. All
yeah.
right.
All right. Have a great day.
You too.